This was presented at AIOC2020 at Gurgaon at the Apple Tree and as a free paper and the invited session. It was one of the best innovations of Apple Tree. I got the best paper for Cataract. That time it was just the design concept. Now we are presenting the actual safety profile and the data that we have collected on this. And the patent for this has been published. It is under the first review now. So basically, phacoemulsification, we know, most of us know about it. The surgeon experience is the most important factor, and the rate of complications is between 2 to 14%. What is important is, as teachers, it is higher with first-year residents or beginners. And complications are seen in both divide and conquer and chop, but it is slightly higher in the phaco-chop technique and unsupervised surgeries, especially in teaching institutes. These are the rate. What is most important is this step of surgery, phacoemulsification, the chop or the rhexis, the 70% of the complications take place at that step. So what were the design changes that I introduced in designing I took a little bit of class 10 physics and integrated it with the design of the dialer. So basically the dialer had a forward angulation of 110 degrees. So what this did was improve the peripheral reach and increase the distance from the posterior capsule. So when you are dialing or chopping, so this improved the safety profile. And the chopper had a 20 degree sideway angulation. Now what this did was aligned the forces. If you remember your high school physics, two forces work best when they are aligned in the same axis. So surgeons who use the 10 o'clock and 2 o'clock ports, basically their chopper and the phaco probe are at almost 90 degrees to each other, so your force is never optimum. So what the 20 degree angle did was more or less align the chopper axis and the probe axis. And this was the safest angle that I could give without reducing the mechanical stability of the chopper and reducing breakage, otherwise the tip breaks. So these are two videos. This is what the chopper looks like from the top view. You can see the side angulation in the left photograph, and the end-on view, this is how it is angled forward. So basically the first video, center video is of the chopper and the side is of the dialer. So even with a dialer you can manage a mature cataract. So gradually the use of the chopper goes down. So aim was to compare the complication rates, phaco times in residents, senior residents and junior surgeons and experienced surgeons. So basically it was all done under peribulbar 2.8 mm incision using an Alcon Infinity machine, grade 2 and 3 cataracts, and in senior residents it was grade 2 and 3 peribulbar around 1200 cases, and in experienced surgeons around 1800. This was over a period of 3 years at Base Hospital Delhi Cant. So these were the results. Now if you see, group A is one with the traditional chopper and dialer, and group B is with the new design. So you can see this is in the second year and third year residents. You can see that there was a drop in the phaco time and the number of complications almost halved. So the percentage wise it was a drop improvement of 4.78% and complication rate of around 2.1%. In the senior residents, again the change was around 3.19% and 1.86%. This was the data over 3 years. And in the senior surgeons, obviously they were experienced surgeons, but even here there was a marginal improvement. We didn't expect much changes in this group, but the phaco time did improve in this group also. So, and what is interesting to note is that the use of the chopper went down because the dialer becomes more effective in harder cataracts also. So the chopper use went down in each group. So actually that also led to a reduction in the complication rate because it is a sharp instrument versus a blunt instrument with a better reach now. So as the chopper use went down, the complications also automatically went down. So basically phaco times and PCR rates, what we found were in line with the worldwide data. There was a significant improvement in both with the use of the angle chopper and dialer. What it does help is transition to phaco in the young surgeons. This was the group on which I tested maximum. And the complications obviously reduced, so it helped in the teaching program of the students, the first year, second year, third year residents. And obviously it gives them more confidence when you can transition to phaco and you can transition from stop and chop or divide and conquer to a direct chop at an early stage. So it helps in their surgical outcomes also. So the advantages are that the chopper has an improved safety profile, it has reduced complications, it helps in the transition to chopping, and it is extremely useful for very hard cataracts. The dialer has now effectively become a chopper replacement for even up to grade 3-4 nuclei and some grades of mature cataracts also. And there's a much more improved safety, and for beginners it is a very useful instrument. Thank you.
Thank
Thanks.
you, Doctor. Anybody wants to say? Thank you, Dr. Kapoor. It's a very good study. And it's been is it a randomized controlled trial which you have done?
Ma'am, it was...
Because how did you randomize?
Ma'am, randomization was based on the, it was basically grade 2 and 3 cataracts for the residents.
It should be a blinded kind of randomization.
It was blinded in the OT because we don't allot cases.
Yeah, because
only it is random cases
should have
given
been
to
a
the
computer
residents and the
generated
faculty.
the methods to do the randomization. This would have been even more, useful and authenticated by a better way of randomization.
This is the initial data
anyway,
that we
you can
came
do
out.
again. There's no problem. What was the overall length? Was it of the intraocular bit?
Ma'am, the tip length in the dialer is 0.8 mm.
Compared to the regular one?
Regular dialers and choppers are around 0.6 to 0.7. The dialer tip is slightly longer because I want to improve the peripheral reach. So it is 0.8 mm.
But what I'm saying is it for a vertical chop or a horizontal chop?
That you are not specified. Sharp edge was at which edge?
Sharp edge was at the posterior edge. You
So
can
it was
use it
done-
for both, direct vertical chop and horizontal chop. It is effective for both. Whichever technique.
Sir, it's a very, very good paper, sir. Is the tip sharp or blunt?
The dialer tip is blunt. The chopper has a ultra fine, very sharp tip. It's a sharp chopper.
But I have a question, but how can you be very sure here
Sir,
that it is the chopper which helps you or the technique? Because mostly with the dialer also you can bend it and get the advantage that you are showing in this case. So that's why randomization is very important to compare.
sir, that's what I
The
said.
same surgeon, fixed surgeon, doing with same technique with the both.
That is why the most of the data is from the junior residents and the senior residents, people who are picking up phaco surgery. And we randomize the cases, we don't allot specific cases to them in our center. So randomization is automatically there.
I think we are on the time. I think it was a good presentation. Thanks a lot,
Yes.
Doctor.
Sir, thank you,
May I call Dr. Rupak Desai, please? Is he there? Yes, ma'am.
Good morning, everyone. My topic is a study on repeatability and agreement of keratometry and refractive prediction between Varion and IOL master. The rationale of conducting this study is to assess the efficacy of Varion image guidance system in reducing the residual astigmatism in patient undergoing cataract surgery. The preoperative planning for cataract surgery involves reliable, accurate measurement of the globe. The Varion is a system having reference unit, planning unit, and digital markers. It helps to assess, plan, and guide the surgeon throughout the surgical procedure, aiming to minimize the postoperative residual astigmatism. The measurement module of the Varion is a non-contact point keratometric device. It captures a high-resolution preoperative reference image, which is used to document the center of the pupil, corneal reflex position, eccentricity of the visual axis, scleral vessels, iris structures. It measures the biometric ocular parameters like corneal radii, magnitude of astigmatism, limbal position and diameter. The planning module of the Varion, it uses the reference images and the preoperative measurement to plan the cataract surgery. It uses the existing different IOL formulas to determine the location of incision, number of location, as well as the proper IOL selection. So the purpose of the study is to analyze the predictability of the instruments for calculation of IOL power and K reading,
Yeah, sure, ma'am.
as well as the Varion predicted ST with the final follow-up, final prescription. The objective was to compare the IOL power between Varion Planner and IOL Master, to compare the K reading between two machines, and to assess the efficacy of Varion Planner to predict the post-operative outcome. A prospective randomized observational study was carried out. The statistical analysis was done with the paired sample t-test and Pearson correlation coefficient test. The 120 eyes were examined. The incision size is 2.2, 2.8 and 3 mm. It's all clear corneal temporal incisions. Now the correlation between pre-op K1 and Varion K1 and IOL master K1, there is a strong correlation. And similarly, in the pre-op IOL master K2 and Varion K2, there is a strong correlation. The similar study was done by the Glober Nemlet. It also shows that the Varion is a suitable alternative tool for the clinical practice. Now the correlation between the Varion predicted final ST and the final ST subjective test at 2 months in 2.2 mm group. It shows a strong correlation between the Varion predicted cylinder and the final ST cylinder. The Ansu Sachdev, it also shows there is no significant difference in accuracy between the two systems, but it has an additional role in astigmatic management. As the Varion, it may help to refine the postoperative peripheral refractive prediction. The similar observation was found in 2.8 mm group, where there is a strong correlation between Varion predicted cylinder and the final ST cylinder. The image guided lens extractor surgery, the study done by Irini et al. Shows that the accuracy and reliability of both the machines. However, the Varion is very useful in conventional manual ink marking techniques for the toric IOL management. Correlation between the Varion predicted ST and final ST in 3 mm group, there is a strong correlation between the Varion predicted cylinder and the final ST cylinder. The Varion system, Rusibella also shows that the Varion system provide a consistent measurement of keratometric values. Now, correlation between IOL master and Varion power, there is a significant difference. The similar study was done by Takahashi et al. Shows that the optimization of IOL constant in the Varion is vital, and once you optimize the IOL constant, the Varion is more accurate as compared to the IOL master. Varion predicted and post-operative accepted refraction by the patient has a less significant difference, just because most of the patients are comfortable without a small correction of plus or minus 2.5 diopter. So such correction are not prescribed to the patients, and because of the high repeatability, it may enjoy an increasing role in today's cataract surgery, especially the toric IOLs. The Variol system still requires the axial length values from another device. Thus, for a same A constant, any difference in post-operative expected outcome must be explained by the difference in actual measurement of K readings. So, to conclude, the Varion is a new technology to give a reliable expected refractive outcomes. Varion and IOL master together can be used for achieving near emmetropia post-operatively and for the better suggestion of IOLs. Thank you.
Thanks, ma'am.
So your conclusion is everybody should have both the
No.
And doctor, that is a very nice presentation, doctor. But in your series of patients, how many patients needed a different lens as far as sphere is concerned and as far as the toricity is concerned when you compare IOL Master 700 with the Varion during the surgery? So you are basically comparing preoperative measurement with intraoperative measurement.
It's basically pre-operative prediction done by the Varion. Varion has a planning unit which predict the post-operative outcomes. So we have compared that Varion predicted outcome with final ST which we give to the patient.
So
cylinder
compared to IOL
values-
Master 500 data, and which formula did you use
In all patients we use a Barrett formula.
You use the online Barrett's or the one which is present within
Present with the Varion, and for the yes, with the Varion. It's
Ma'am,
online.
you are
It's
aware
online.
that as far as toric calculations are concerned, the online Barrett's toric calculator is far superior to the software which is there within the Varion or with the IOL Master 500. The online software gets updated at least once a year and sometimes twice a year. So those formulas are far better as far as the toricity is concerned. So your paper is to compare between the predictability and the agreement. So what was the predicted sphere and cylinder by IOL Master 500 and with the Varion? We need those two tabular columns, ma'am.
Yes. We have compared the prediction of Varion, the Varion which has prediction, and the final outcome which we have prescribed to the patient. And we have compared the IOL master and Varion for the K reading values.
So you did that only for the K reading values, not for the choosing
Not for choosing
the intraocular lens.
No.
So you chose the intraocular lens only based on the Varion readings, not on the IOL master.
But when we calculate we calculate the lens power with both the machine. But what we have implanted is according to the variant. And the difference between two is significant, which the IOL power which we find out with the help of IOL master or with the variant, there is a significant difference. But in this study, we have implanted all the IOL power according to the suggestion done by the variant machine.
But what about biometry? It comes from the IOL master?
It
The
is
axial
calculated within the axial length is from IOL master. So that is the limitation. So any difference given point, any difference you find in predictive outcome is just because of change in the K reading.
That's why you have to have
So we need to optimize the A constant. That is
Ma'am,
must.
you're referring to the K reading after the cataract is removed. Are you talking about that, or you're talking about the preoperative?
Preoperative.
Preoperative. Thank you, ma'am.
Preoperative.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
May I request Dr. Bharti ma'am to present her paper now? May I present you Dr. Bharti Kashyap, please?
Good morning, chairpersons. So my topic is, excuse me, इसको full screen कर दीजिए. Excuse me. Good morning, everyone. My topic is clinical outcome of monofocal plus IOL with enhanced intermediate function with non-diffractive novel EDOF IOL. The purpose is to compare clinical outcomes of a new monofocal plus IOL ICBU with enhanced intermediate function with non-diffractive new EDOF IOL DF215. The DF215 has two smooth surface transition elements, elevation and curvature changes that uses X-wave technology, and it stretches the wavefront. The ICBU has modified aspheric anterior surface of the optic. 90 days outcome measures were binocular, uncorrected and corrected distance, intermediate and near visual outcomes, contrast sensitivity, binocular defocus curve, spectacle independence, photic phenomenon, dysphotopsia profile. The method was prospective non-randomized comparative study, single surgeon, tertiary care eye hospital. Data was analyzed with SPSS software version 20, group 1, 20 and 20 patients, 40 eyes, new monofocal EDOF IOL ICBU, group 2, 20 patients, 40 eyes, non-diffractive EDOF IOL DF215. These are the inclusion and exclusion criteria. The analysis of preoperative patient data of two groups for number of eyes, age, gender, axial length, pre-op myopic sphere, pre-op hyperopic sphere and pre-op cylinder were comparable. The distance visual acuity shows better uncorrected distance visual acuity and best corrected distance visual acuity in group 1 ICBU. Difference is non-significant. Intermediate visual acuity shows significantly better uncorrected and distance corrected intermediate visual acuity at 66 cm in group 2 DF215 p.00, and again intermediate visual acuity at 50 cm shows significantly better uncorrected intermediate visual acuity and distance corrected intermediate visual acuity in group 2 DF215. The near visual acuity shows significantly better uncorrected as well as distance corrected near visual acuity at 40 cm in group 2 DF215 p.00. So binocular corrected and uncorrected distance visual acuity shows comparable result. Uncorrected and distance corrected intermediate visual acuity at 66 cm and at 50 cm both is significantly better in group 2 DF215. Binocular uncorrected and distance corrected binocular near visual acuity shows significantly better result in group 2, that is DF215. Modular transfer function for contrast sensitivity shows comparable results between the two groups in photopic and mesopic condition. The statistical analysis for binocular defocus curve group shows group 2 DF215 IOL has significantly better result at versions of 1.5, 2 and 2.5. This is the graph, and you can see the group 2 has significantly better vision at 1.5, 2 and 2.5. Post-operative reading speed at 66 cm. The proportion of patients having post-operative reading speed at intermediate distance were significantly better in group 2, p.008, 95% confidence interval, 10% and 61%. The proportion of patients not at all bothered by starburst, halos and glare were comparable between group 1 and group 2. At 3 months, Qubit questionnaires were applied for this, and the the proportion of patients having a spectacle independence at intermediate and near distance 66 and 40 centimeter was significantly more in group 2 DF215 in bright light condition, and the proportion of patients having a spectacle independence at intermediate and near distance 66 and 40 centimeter was also significantly better in group 2 in dim light. So the group 2 did well in bright and dim light, intermediate and near vision distance also. IOLSAT questionnaires were applied. So what this study adds, the bright light and dim light at an intermediate visual acuity at 66 centimeter and 50 centimeter is significantly better in group 2 accuracy of IQ VVT IOL DF215 than group 1 IHANS IC-BOO, thus facilitating intermediate tasks significantly like computer work, reading labels in the shop, cards, board games, crafts, playing music in bright and dim light, and photic phenomenon were comparable. These are the references. Thank you, and I have no financial interest.
Thanks, Pam, for the beautiful presentation. All aspects, including the statistical analysis, the group differences and everything. Only one question I would like to ask you, ma'am. On what basis this principle is there between the trifocal and the no-IOL? Trifocal is dividing light, I suppose, is 50,
Trifocal
30,
divides.
50, 30, 20 or something
Yeah,
like
it
that?
divides, and this IOL stretches the focus, because in the center, this is not the study of trifocal and VVT. This is the study between VVT and the IC-BOO. But trifocal divides the light, splits the light, and here it does not split the light, it stretches the wavefront focus, because in the center there is an elevation and there is a curvature change. The elevation, elevation and curvature change, what it does, that the central light speed is relatively slower and peripheral light speed is same. So the wavefront focus is stretched, so you get a depth of focus.
That was excellent, ma'am. Thanks, ma'am. Pleasure.
Beautiful. Thank you.
So she has two presentations.
Yes.
So I think she has presented this.
Yeah, no wonder.
There's one more I can present.
I think we'll go.
She can combine. I think if you just come and finish both, will be nice. Please come. Yeah.
Right. I got confused with the author.
I think we'll be going by order only. You have any other
Yes,
presentation?
I am comfortable
Please,
in any
please.
situation.
Please have, sir. Do we have the next presenter who is a non-ratified member? So, do we have them?
Who's not that?
Maunik Bolishetty, ma'am. This person.
Monica.
Yeah?
So
Please,
they can't
please.
present, they can?
Of course they can.
Marks neither.
No marks, but they will.
Please.
You start, ma'am. Your time starts now.
Slides. Good morning, one and all. Preferred practice pattern FACA management in adults in India, a survey. So the incidence of post-cataract surgery leading to AFACA is less than 1%, but causes a lot of morbidity to the patient as well as a lot of anxiety to the surgeon as well. Management of FACA has undergone paradigm shift from anterior chamber IOLs to various designs of scleral fixated IOLs and retrofixated iris claw lens. Given the myriad of choices of IOLs in the management of AFACA, with many comparative studies showing similar visual outcomes, choice of IOL depends upon the operating surgeon. Also, the other factors which included the IOL availability, adequacy of the capsular support, coexistent nucleus or cortex drop, primary and secondary surgery at the time of cataract surgery, or planning the surgery after a couple of days. In this survey of cataract surgeons across India, we sought to assess preferences in the surgical management of AFACA. It was done after the approval of Institutional Ethics Committee. A questionnaire was designed from the hospital primary team, which was administered, and the Cherry's guidelines was followed. It was fielded to the members of AIOS with valid email IDs and phone numbers, and WhatsApp messages were sent from March to April 2021. Single responses from the patients were ensured by hosting the survey of the SurveyMonkey platform and tagging the responses along with the IP addresses. Responses were registered as complete when all the survey questions were answered, and the questionnaire recorded the type of surgeon, the years of experience, type of practice, and the area where they represent, like north, south, center, and so on. And also the number of cataract surgeries performed per month, along with the number of AFACA patients encountered in practice. So the survey questionnaires were sent out to 10,000 ophthalmologists, but we received the responses from 481 surgeons, with 77% being anterior segment surgeons and 23% as vitreoretinal surgeons. Participants were almost equally distributed among the terms of institutional and private practice with 40 and 38%. And the remaining 103 practitioners were engaged in both institutional as well as in private practice. So coming to aphakia management during primary surgery without nucleus drop, 81% of 81% of the participants said that they managed the surgery themselves, while 4 preferred to manage the aphakia in a second sitting. A separate of 4% each preferred to call a VR surgeon in the same sitting, as well as 4% referred it to a VR surgeon in the second sitting. In the same time, a 3-piece IOL in the ciliary sulcus was the preferred choice of IOL. And when there was an inadequate capsular support, retrofixated iris claw lens was the choice of IOL. Aphakia management during primary surgery with nucleus drop, 42% of these participants prefer to refer the patient to a VR surgeon in a secondary sitting, while 27% called a VR surgeon in the same sitting when the VR surgeon and along with all the equipments are available. In terms of IOL placement in this scenario, a vast majority of 85% prefer to leave the patient aphakic. Practice for IOL placement during secondary surgery in eyes without capsular support. 75% participants preferred retrofixated iris claw lens with a peripheral iridectomy at the same time. For those who preferred SFIL, 125 participants preferred a sutured SFIL, while 108 preferred a sutureless technique. And for those choosing sutureless SFIL, the glued IOL was the most preferred, followed by Yamane. Comparison in practice differences in practice patterns among anterior and posterior segment surgeons. It was noted that 65% of VR surgeons preferred SFIOL, with more preference towards a sutureless technique. Also, among the patterns of aphakia management, significantly higher proportion of younger surgeons preferred retrofixated iris claw IOL when encountering aphakia. Similarly, doing so, sutureless SFIOL, younger surgeons preferred the Yamane technique compared to the surgeons with higher experience. So, they showed in aphakia, patients without adequate capsular support, anterior segment surgeons were more comfortable in managing cases with no nucleus drop about half of the times, and with little assistance with VR surgeons. When they saw a patient in the OPD who presented with aphakia, they chose SFIL more frequently rather than the patient when they encountered aphakia in intraop. And VR surgeons preferred an SFIOL much more as compared to the anterior segment colleagues. While choosing an SFIOL, anterior segment surgeons preferred suture type, while VR surgeons chose sutureless techniques. However, there may be a fear of IOL drop while performing sutureless technique requiring sutureless SFILs due to inherent maneuvers involved. This fear is also demonstrated while doing sutureless SFILs, where anterior segment surgeons preferred a glued IOL as compared to their VR colleagues. One of the limitations could be an underrepresentation of the ophthalmologists from the rural practice. So this survey showed current trends in the management of aphakia amongst Indian ophthalmologists. Retropupillary fixation of iris claw was preferred more by anterior segment surgeons, especially in the primary cataract settings, with VR surgeons with more experience preferring a SFIL. A similar survey may be repeated periodically to document changing trends in the surgical management of aphakia in future. These are my references. Thank you.
Are you doing cataract surgery?
Yes, sir.
So what is your preferred technique?
I am undergoing training for VR surgery.
Yo, this is
so
just a Google survey.
No, my purpose of asking this question is why you decided to conduct this study?
So
I know.
get a consensus about what are the preferred management, and also if there, as we observe the trend that VR surgeons.
The paper
who
clearly
are-
says that it is
Anyway.
a preferred practice pattern. So
Anyway,
she
this
has
is
that
not
much
a
of liberty
PPP.
to decide which one is
This is not a
It's not that which
PPP.
surgery she does. So
This is just
I think that
Doctor,
much of liberty should be given for a
mm,
free paper. Please, thank you. Thanks, ma'am. Next patient.
Nice.
I think we have to have
Sir,
jump
excuse
the
me.
queue. Somebody
One
has to go.
person-
Dr. Jayagopal Agarwal. He has a presentation in the other hall also, in the same slot.
Last but one. 1884.
Artificial intelligence.
Yes, thank you. On the page 1. Yes. Yes, yes. Thank you. Good morning to everybody. My paper is on comparing the new trend of artificial intelligence based on IOL power calculation over the regression formula. I have no financial interest. The purpose of this retrospective study is to compare the accuracy of widely used IOL power calculation formula, namely in artificial intelligence based formula, we have taken the LADA Super and Hill RBF. And for the regression formula, we have taken Barrett's, Holiday 1, Hopper Q, Haggis, and SRKT. Details of 267 patients are collected from our hospital. Now, how does the artificial intelligence based formula works? When we upload the data of the patient, artificial intelligence based formula finds a distinct pattern in the apparently random cloud of data points already created by the large number of cases based on the pattern of recognition of artificial intelligence. That is the purely data-driven IOL power calculation approach, and therefore is free from the limitation of expected lens position and also free from the limitation inherent to the standard formula. So these are adaptive dynamic and learning process and continuously become better and better by updating itself by entering the large number of surgical outcome into the cloud. This is just basic idea how it works. What we get collected from our investigation, it is input is done, and there are hidden layers. In the hidden layers are the variables of the each formula, and after the complex analysis, we get the output as a result. The pre-operative method is the IOL master readings are also used for including the axial length, corneal curvature, and other related eye parameters along with the complete examination of the eyes. Patients were distributed in the groups for the axial length. Axial length more than 24.5 millimeter. Group 2 is the axial length between 21 and 24.5, and axial length below 21.5. 1 month post-operative by the same profession and the autoref instruments, measurements were done for the best corrective visual acuity, post-operative actual dioptric power, and the number of dioptric errors. Here it is in these retrospective studies we have examined the 423 eyes from 267 patients. The inclusion criteria are as follows. Patient, as it is simple, it is patient who had cataract with the complete pre-examination data and post-operative data, those undergone cataract surgery without any complication. IOL used are Acriva, Hoya, and Lucia. Pre-operative biological measurement using the IOL Master 700. These are the data collected from my study and analyzed by SPSS software. The means were showed in the mean standard deviation, refractive mean numerical error, and mean absolute error of IOL formulas are different axial length groups are calculated and compared. And refractive error absolute values are 0.25, 0.5, 1, and 2 diopters. Mean absolute error is the indicator for the IOL power formula prediction accuracy. The standard deviation of the mean absolute error shows the accuracy of the prediction is very good. Centroid residual astigmatism error are calculated for only for the toric IOLs. Here in this series, there are only 26 cases. These are the demographic slides. Now come to the numerical errors. Here, numerical error shows that the Hill RBF and the LADA Super formula has the least numerical error, so they are better. Now come to the next is mean absolute error, which is very important for the accuracy. Now here again the LADA Super and the Hill RBF are the least mean absolute error, so they are really they are good with better than the other formulas. These are the sensitive formula predictions, and here again the Hill RBF and LADA Super formula gives the most post-operative errors. The minimum post-operative error for most eyes within the 0.5 of spherical equivalent. Now it is a table shows the whole chart, and here again it shows the the LADA super formula gives the more accurate result because within the 0.5 diopters as compared to the other formulas. Now for extreme eyes, LADA super formula is better than other formula because here again mean absolute error is smallest in case of long eye, or in case of short eye again the prediction value is more again prediction is more within the 0.5 diopters, so it is better. Now for the case of toric calculation and the post LASIK calculation, here again the for toric calculation, as sir said, that Barrett toric calculator is very good for the cylindrical part, so we have mixed it with LADA superpower for the spherical part and the Barrett toric calculator for the cylinder part. We get the maximum good results. And the post LASIK calculation, there is no artificial intelligence based formula till now. So in case of the toric IOL, we have also calculated the centroid residual estimate prediction error. Here again, the LADA super formula along with the Barrett toric calculator gives the minimum, in both in the WTR and ATR, gives the minimum error. So in addition, thus adding the result of toric astigmatism in the part of the Barrett toric calculator to the result of the artificial intelligence based formula gives the excellent results. So this is the same thing. And now to conclude, artificial intelligence formula is a single answer to IOL power calculation. It incorporates the sweet spots of many existing formula. It is totally data driven based artificial intelligence formula without estimating the ELP, and thus artificial intelligence formula begins the game changer in the grandmaster of biometry. Thank you.
Thank you, doctor. I have one question for you.
Yes.
Recently, the Kane formula and the DGS formula, both of them are AI-driven formula.
Yes.
They are supposed to be giving superior outcomes when compared to Barrett's
but
and the rest.
Study, it was not. I have not included that.
Yes, sir. But Kane has been there for the last 4 or 5 years.
But the Kane formula should be. Yes, it is no doubt. In England, it is more prevalent. But now it needs more validation because it needs more number of cases to be validated.
Currently, all the papers are saying that Kane is far better than the rest, sir. So when you talk about AI, we had to think about these formula also, sir.
This is a retrospective study, if I'm not mistaken.
Yes, it is a retrospective
so
study.
because there are a lot of variables.
Yes,
You
yes.
included toric and so many.
Multiple length
So the-
groups, axial length.
Sample size appears in a
For
different.
short eye or long eye, I have also added that.
Let's see.
Posterior corneal astigmatism is not considered into the grade 3 formula or generation 3 formula, while in arterial intelligence formula, that Hill RBS, posterior corneal astigmatism is considered. So that could be the difference in the IR power also.
No.
Okay. Thank you, doctor.
Okay.
Thank you, sir.
Yeah, okay.
So we will
Next
call,
speaker, we call upon Dr. Smith Sutte.
clinical outcomes and patient satisfaction following bilateral implantation of panoptic toric. Thank you.
A very good afternoon, respected judges, panelists, my dear friends and colleagues. The topic of my presentation is clinical outcomes and patient satisfaction following bilateral implantation of panoptic toric IOL. My co-authors are consultants to Carl Zeiss Meditech. I have no financial disclosures to make. The study was, however, supported by a grant for the investigator-initiated trial funded by Alcon. In recent times, an array of multifocal intraocular lenses are available to aid in spectacle independence, turning cataract surgery into a potential cataract cum refractive surgery. Preoperative astigmatism of more than one diopters is seen in as much as 47% of the eyes, and various methods are employed to combat it, including toric IOLs. A residual astigmatism of more than one diopter can severely impact the vision, and in general, the goal when correcting astigmatism during cataract surgery should be a post-operative residual astigmatism of less than 0.5 diopters. The new Panoptix IOL features an innovative quadrifocal design with a central diffractive region of 4.5 mm, optimizing near and intermediate vision over 40 to 80 cm. The Enlightened technology enhances the energy light utilization at 3 mm aperture to 88%, which is 6% higher than traditional multifocals. In this, the extended intermediate focus is shifted to the distance point, technically making it a modified quadrifocal IOL. As compared to Restore, Panoptix has 15 diffractive rings with a near add of 3.25 diopters and an intermediate add of 2.17 diopters. The central diffractive region is of 4.5 mm to aid in good intermediate as well as near vision. So we undertook this clinical study to evaluate the clinical outcomes with this IOL and the real world evaluation. So 30 patients underwent bilateral implantation with this IOL. All IOLs were implanted were of standard range. All eyes were targeted at emetropia using the Barrett TK toric formula. Post-operative examinations at 6 months included uncorrected and corrected distance, intermediate and near visual acuities. A defocus curve testing was charted. Reading spares were evaluated with Salzburg reading desk, and subjective outcomes using IOLSAT quality of vision questionnaire were assessed. Post-operatively at 6 months, all patients had a binocular UDV of 20 by 20 and 30% patients had even 20 by 16. The spherical equivalent was within plus minus 0.13 for 82% of the patients. All eyes had a refractive cylinder less than 0.5 and 88% of the eyes had even lesser than 0.25 diopters. ETDRS charting was used for uncorrected and corrected near as well as intermediate acuities, and the results were quite good. Reading speeds assessed with Salzburg's reading desk at 40 cm was 166 words per minute, and at 66 cm it was 164 words per minute. The binocular corrected defocus curve charted showed good functional vision of 20 by 32 or better over 3 diopters range of defocus. IOL's quality of vision questionnaire was done, and the patients were asked about the vision in bright and dim lighting conditions up close, at arm's length as well as at far away distances, and revealed high patient satisfaction. In a comparative study, accuracy of Panoptix yielded better near visions than the EDOF Symphony. In a study assessing the outcomes of Panoptix IOL, 96.9% of the patients achieved spectacle independence and expressed a high degree of satisfaction. In another study comparing the visual quality and subjective outcomes between 3 trifocal and a bifocal IOL, Panoptix had better intermediate performance. Thus, to conclude, in our study, Panoptix toric IOL allowed complete visual restoration with excellent visual quality outcomes and patient satisfaction, and appeared to have good rotational stability as well. No eye developed PCO or glistening by the end of 6 months, affecting the results. Thank you so much for your kind attention.
Thank you.
Thank you for the excellent presentation. What was the night vision in these patients, since the lens is yellow in color, which filters the violet and blue color? Have you noticed any decreased vision, or they require more light
no, sir,
at
as
night?
of now we have not. We utilize the IOL quality of SAT vision questionnaire. So basically the same questionnaire was also given to patients at 15 days, and then we compared it at 6 months, which was the endpoint of our study. So the question looks at vision and patient's experience at all ranges of vision, from bright light to dim light, at all distances, near, intermediate as well as this. So as of now we have not found out anything on.
Why didn't you do a comparative study? Why?
Ma'am,
just
this
an observation. No, this is
yeah. So basically this study we started in February 2020. Then following COVID, a lot of this is a prospective study which is still ongoing.
I know, but it should have been comparative.
Yeah,
no?
so in our
With
next
what?
phase
Because
we are
there
comparing
so many
it.
lenses claiming so many things.
Yes, ma'am. In our next phase, we are comparing it with
Can
3
be
different
double
lenses. So there are 3 different prospective studies going on, and this still remains an ongoing study.
Okay, so it's a somewhat incomplete study rather. Sample size? How did you
Sample size,
calculate?
as of now, we have
Because-
implanted in this particular study 30
No,
patients.
what basis did you take that sample size? How did you calculate?
So we initially
just
had a
take
sample size of
arbitrarily
33 patients. For minimum significance, we have evaluated 30 because our enrollment was severely affected following COVID, and this was a company-funded
We're only asking you
investigative
what is the
trial.
sample size which you would have.
Yes, sir.
Shall we call the next patient now?
Yeah,
Thank
they are
you.
calling about the power of the study, but it's okay. You can just do it. What he says is right. Thank you.
Thank you, sir.
Next one. Are you there?
Madan Gopal.
Please
Dr.
come,
Madan
Doctor.
Gopalan.
So results of novel CMT flex IOL for aphakia in comparison with scleral fixated IOL and the iris claw IOL. Thank you.
Thank you, sir. So, speaking about the results of the novel CMT Flex scleral fixated lens in comparison with the standard SFIOL and iris claw lens. It's no coincidence that just a couple of papers ago, we were seeing what the preferences of surgeons were in case of absent post-capsular support. So I have no financial disclosures, whereas my friend Dr. Nivian is the innovator and the patent holder. Right, a little background about the subject. As we were just seeing, in case there is capsular compromise, the age-old options have been to use a scleral fixated IOL or an iris claw lens. Now each of them have their own advantages and disadvantages. In doing an SFIOL, you place the lens in a more anatomically correct position, and you don't have pupillary disturbance. Whereas on the flip side, it's a little more challenging surgery, it takes time. In iris claw lenses, the surgery itself is pretty simple, but you're anchoring the lens to an important structure like the iris, so you have the chance of distorting the pupil, having glare, producing some inflammation. Well, the CMT Flex lens was designed to combine both the SFIOL and the iris claw, to retain the advantages of both while eliminating the disadvantages. The advantages being that it's a simple lens to fix, and the disadvantages of anchoring it to the pupil are eliminated. We still anchor the lens to the sclera. Now the design of this lens, the method of fixing it, everything has been published in standard journals. The videos have received a lot of acclaim in conferences. People have come up to us and said it's all very good, but actually how does it compare in real life to SFIOL and iris claw? Well, the aim of this particular study is to address that pressing question. We wanted to assess the visual and refractive outcomes of the CMT Flex lens and compare it with the standards. We also wanted to look at, more importantly, we also wanted to look at the undesirable effects. This question keeps coming up often. So how was it done? It was done in 2 tertiary eye care hospitals in Tamil Nadu. It was a non-randomized study for obvious reasons, because randomizing in case of surgical aphakia becomes difficult because some cases are managed then and there in the OT. So we had strict criteria. We took up only cases with surgical aphakia. It was done for 3 months. We recruited 112 eyes, and about 38 eyes were lost to follow-up. We had 73 eyes standing after 6 months. So they were in 3 groups as follows. Now these are all published procedures, so for brevity and I'll have to present it in 6 minutes, so I'm not going into the surgical technique. But suffice to say that CMT Flex IOL was done with the handshake technique, and the T-shaped haptics rested under scleral flaps at 3 and 9 o'clock meridian. So coming to the results, what do the numbers say? I'm not going to complicate things too much. I'm not going too much into p-values and refractive details, but let me just say there were no difference in the 3 groups with respect to age, gender, laterality, IOL power, or axial length. But we see that the iris claw lens patients, there was a shorter gap between the primary surgery and placement of the secondary IOL, and the lenticular remnants and the need for a full PP was obviously lesser in the iris claw group. When it comes to duration of surgery, we see that patients who underwent iris claw lens surgery had a shorter duration, and 1 person with a scleral fixated lens needed a re-surgery within a month to refix the haptic. The iris claw lens patients were shown to have a hyperopic refractive shift that was significantly different. It is seen here, the refractive error shows a hyperopic shift in this box whisker plot, whereas coming to best corrected visual acuity, all 3 lenses were same at 1 month and at 6 months. Moving on to the important part of undesirable effects. We see that there was no significant difference between the 3 groups with respect to parameters like corneal edema or IOL dislocation. But when it comes to AC reaction, having an irregular pupil or having an IOL tilt, the iris claw lenses, the group had a little more significant change. Whereas a couple of people with the standard scleral fixated lens had haptic exposure at 6 months. That was significantly more. So that was the numbers, that's what we saw. Moving on to the discussion, our study has actually brought out some things that we already know. For example, the iris claw lens surgery takes lesser time, the visual outcomes are comparable, and that iris claw probably you will anticipate a little more inflammation because the iris is disturbed. But what does our study add? What does our study add to the literature? We found that the CMT Flex lens is comparable to both the standard options as far as the eventual visual acuity is concerned. And more importantly, I keep stressing that the complication profile is also not very, very high, or in fact, it's much better than the SFIO lens and the iris claw lenses. Of course, our study was not without limitations. We had a lot of limitations. It was a small sample size. And as I mentioned, we couldn't randomize the study because, there are certain cases with absent capsular support where the primary surgeon, the surgeon who's doing the cataract surgery, feels he can manage it. So we couldn't, bring the patient out and take him back inside. It was a short follow-up period. Obviously, it was before COVID, and we lost a lot of patients to follow up after that. Nevertheless, there are certain valuable conclusions that this pilot study could tell us. In CMT flex lens, in comparison with the SFIOL and iris claw lens, we found that the refractive outcomes are better than the iris claw lens, and visual outcomes are definitely comparable to the standard options of the 3-piece SFIOL and the iris claw lens. And when we talk about fixing a lens to the sclera, most importantly, we need to know about the haptic exposure, and CMT flex lens haptic exposure is similar or better than the SFIOL. Finally, when we talk about inflammation, pupil distortion, and other major side effects in the posterior segment, we see that the CMT flex lens is comparable to the SFIOL and really better than the iris claw lens. Thank you for patient audience.
On the dot.
On the dot you finished, huh? Good.
Thanks, doctor. Doctor, was there any case where this lens could not be implanted?
Initially, sir, when we were out of the study, initially even before the study was planned, when the surgeons were getting used to the lens, what happens was we used to tear the lens. We used to pull the lens a little more hard. But then we realized there's no point in pulling. We just have to push with the injector. The other one comes out just like that.
What's the follow-up period?
This particular study, we have a follow-up period for 6 months, ma'am. All the eyes completed a 6-month follow-up.
It's done in primary setting or secondary?
CMT flex is always in the secondary setting. So.
It comes in one single size or two sizes, doctor?
It comes in a single size.
Single size.
It's a major disadvantage, no? Secondary setting. It's a major disadvantage.
Sorry, madam.
A second surgery is a major disadvantage.
Yes, exactly. Yes,
I mean, that itself is a big deal because you can do SFIOL or other one on the table.
Primary on table.
Thank you, doctor.
Thank you.
Thanks, doctor.
Dr. Bharti, your next paper, please.
Good morning. Good morning, chairpersons. Thank you for giving me this opportunity to present my paper. My topic is comparative analysis between bilateral implantation of standard diffractive trifocal intraocular lens and new continuous range of vision intraocular lens in Indian population. The purpose is to evaluate the clinical outcome and patient satisfaction after implantation of diffractive trifocal intraocular lens PanOptix TFN2 and new continuous range of vision intraocular lens Technis ZFRU5. The prospective non-randomized comparative study, single surgeon, tertiary care eye hospital, data analyzed with SPSS software version 20. Group 1, 20 patients, 40 eyes, bilateral diffractive trifocal IOL, PanOptix TFN2. And group 2 has 20 patients, 40 eyes, bilateral continuous range of vision, IOL Technis ZFRU5. Outcome measures were taken at 90 days. Uncorrected distance visual acuity, photopic and mesopic best corrected distance visual acuity, uncorrected intermediate visual acuity 80 cm, 60 cm, distance corrected near visual acuity 40 cm, photopic and mesopic distance corrected near visual acuity at 33 cm. Contrast sensitivity, binocular defocus curve, day and night driving and nighttime activities, dysphotopsia profile. These were the inclusion and exclusion criteria. The analysis of preoperative patient data of two groups for number of eyes, age, gender, axial length, pre-op myopic sphere, pre-op hyperopic sphere, and pre-op cylinder were comparable. And group statistics and t-tests for equality of means were done in all the for all the outcome measures. And we found that the binocular uncorrected distance visual acuity between bilateral trifocal group 1 and bilateral CROV group 2 shows better photopic uncorrected distance visual acuity in group 1 as compared to group 2, but it is comparable. The best corrected photopic distance visual acuity 3 months post-op showed better photopic best corrected visual acuity in trifocal group 1, but difference was comparable. The best group statistics and t-tests for equality of means for mesopic binocular best corrected distance visual acuity showed better mesopic best corrected distance visual acuity in group 2, but it was non-significant. Again, the statistical analysis for binocular uncorrected intermediate visual acuity at 80 cm shows better result for group 2, the CROV lens, but it was non-significant. And for 60 cm also, the results were comparable between the two groups. For 40 centimeter binocular distance corrected near visual acuity, the results were comparable. The photopic near visual acuity at 33 centimeter between group 1 and group 2 showed group 2 is better and difference is significant. P is 0.00. And for mesopic near visual acuity distance corrected at 33 centimeter, again group 2 is significantly better, P 0.00. The contrast sensitivity photopic with glare was comparable between the two groups at 5, 10 and 15 CPD, but contrast sensitivity mesopic without glare was significantly better in group 2 at 5 and 10 CPD. Group 2 means continuous range of vision. And again with glare, without glare, it was significantly better in bilateral CROV IOL group 2. The statistical analysis for binocular defocus CROV Z of RU 5 showed significantly better result at versions of 3 diopter. This is the graph for the same, showing the significantly better vision and 3D focus. The QVIT questionnaires were applied. The proportions experiencing binocular glare often and very often was lower in continuous range of vision versus group 1. The difference was significant. 13 out of 20, 65% patients in group 1 versus 2 out of 20, 10% patients in group 2 experience halos for often and very often. The difference of 55% for combined often and very often is significant, is P 0.0004. Occasional experience of halo was significantly less in group 2, means halo occurrence was significantly less in group 2. So CROV IOL decreased ZF RU5 has significantly more satisfaction with nighttime activities than group 1. Patients able to read menu in the dimly lit restaurant, patient able to see objects and read street lights in the evening or at night, patients able to see steps or curves in the evening or at night. It was better in the group 2, significantly better. Nighttime driving was also statistically significantly better in group 2 CROV lens because it has a UV filter also. And 19 out of 20 patients in group 2 versus 16 out of 20 patients in group 1 opted to choose again this intraocular lens. But again, this difference of proportion 15% is not significant. So what this study adds, bilateral implantation of CRV IOL results in continuous range of vision without any gap, with a flatter defocus curve at intermediate zone and significantly better near vision at 33 centimeter and significantly better contrast sensitivity at mesopic conditions, significantly less photic phenomenon. So conclusion is gaps in visual range problem, nighttime activities problem and dysphotopsia problem. All these in trifocals may be solved by CRV IOL. I have no financial interest. These are the references. Thank you.
Thanks, ma'am.
We'll call the next patient.
Yeah.
I have a question, but she'll get angry if I ask. You have a question?
I did have, but I thought you would get angry.
Next topic is on functional evaluation of corneal endothelium following flax compared with phacoemulsification by Dr. Palak Chiranya. Please start, doctor.
Good afternoon to one and all present here. My today's topic is functional evaluation of corneal endothelium following flex as compared to conventional phacoemulsification. We have evaluated corneal endothelium using two parameters, the central corneal volume and endothelial cell density in this study. Corneal edema is one of the most frequent early post-operative complications of phacoemulsification, which can lead to permanent serious visual disturbances. It is determined by Scheimpflug imaging, that is pentacam. Because the corneal endothelium maintains water content in the cornea due to its barrier and pump function, the corneal volume can be considered indicative of the entire endothelial cell function in the area. Central corneal edema is different from peripheral because of the difference in their origin and nature of development. The importance of endothelium in maintaining the transparency of cornea is well known in literature. This endothelial cell count is measured with non-contact specular microscopy. However, specular microscopy shows only the number and morphology of endothelial cells and does not necessarily indicate the functional status of these cells. Therefore, the best method of functional evaluation of corneal endothelium is volume stress index. It is a simple and non-invasive method, and it implies that when corneal volume increases following surgery with decreased number of endothelial cells, the residual cells must compensate for the increased task and elevated VSI can be seen. It indicates both barrier and pump function and is easier to calculate
with the help of following formula. The aim of our study was to analyze the changes in central corneal volume and endothelial cell density following femtosecond laser-assisted cataract surgery compared to phacoemulsification. A primary objective was to compare these two procedures with the help of Scheimpflug imaging and non-contact specular microscopy, and our secondary objective was to assess the best corrected visual acuity changes before and after the procedure. This was a hospital-based prospective and comparative study. We included all the age-related uncomplicated cataract in the age group of 40 to 70 years who were able to give consent, had clear cornea with no ocular morbidities, minimum endothelial cell count 2200 with nuclear sclerosis 3 to 4. And we excluded all the patients who had prior corneal infection, any other ocular morbidity, severe dry eye disease, uveitis, glaucoma, etc. The sample size was calculated using the following formula with the standard reference published in Tax L et al. In their study, and the sample size came out to be 90. Thus, we took 45 patients in each group with informed consent, and complete ocular with systemic examination was done for all of these patients. The patients were randomly assigned to either group by the surgeon, and all the surgeries was done by a single surgeon. Patients were followed up at day 1 and 1 month post-operatively. So coming to discussion, the endothelial cell damage is the main reason for increased corneal volume post-cataract surgery. Studies using specula show only the number and morphology, not their function. Hence, we used a new parameter to assess the functional changes in endothelium, that is VSI. Our study shows that following, this is the graph showing endothelial cell count. The orange one is other patients who have undergone flex, and the blue one are the patients who have undergone phaco. We can see that in this study, there is a linear decrease in endothelial cell count in both the groups, but the decrease is more in phaco as compared to flex, and p-value is significant in both the groups. When we see the central corneal volume, we could see that the blue color, that is the phaco patients, the rise in central corneal volume is more in phaco patients as compared to flex on day 1 post-operatively, and on 1 month, the value is more in phaco as compared to flex, but the difference becomes insignificant on 1 month follow-up. When we studied volume stress index, in the graph we could see that following surgery, there is a decrease in VSI. VSI was greater after the surgery. However, as in the post-operative period, the VSI gradually decreased. This indicated that the endothelial cell function improved after surgery along a course of 1 month. Changes in VSI is significant in both the groups. Our secondary objective was to assess the best corrected visual acuity changes in both the group, and on 1 month follow-up, we did not found any statistically significant difference in both the groups. However, there are certain limitations to our study. Our study had a shorter follow-up period as compared to other studies, and we did not evaluate the corneal changes post-surgery in a larger diameter of cornea. Also, the morphology of endothelial cells was not considered. However, changes in the central 3 mm of cornea does provide an idea of the effects of flex versus phaco, and we can infer that flex gives superior results to phacoemulsification in terms of corneal damage on short-term follow-up. The availability issues and cost difference makes its use limited. In conclusion, we can conclude that phacoemulsification technique has more effect on endothelium due to greater energy used in the procedure. When comparing phacoemulsification to flex with respect to changes in corneal parameter, the difference between the two groups is statistically significant in our study, with flex giving superior results to conventional phacoemulsification. However, visual acuity in terms of logMAR is statistically insignificant in both the groups. But our study had a shorter follow-up, hence longer-term studies with larger participants are required to ascertain the efficacy of one procedure over another in terms of corneal changes and visual acuity. These are my references. Thank you.
Thank you. As you rightly said, I think the follow-up is quite less for an endothelial parameter.
Yes,
wouldn't it have been better to study percentage loss of endothelial cell count, ECC, because that's a more objective assessment, rather than an index which is liable to change with time? Yes, because in 1 month the VSI in 6 months may be equal. Because most studies have proven that the two procedures are pretty much equal. All things, other things also they have considered.
Yes,
so we can't give a kind of have a sweeping statement that this is causing endothelial loss to such an extent.
Yes,
okay.
Nice paper, doctor. Thank you.
Thank you.
Now we call upon the last speaker of the session, Dr. Rajendra Prasad. He'll be speaking on hydrodissect new surgical technique in the management of complex posterior polar cataracts. Welcome, sir.
Good morning, friends and chairpersons. It's a great pleasure to be here with all of you in this beautiful afternoon. The topic of I'm not used to this actually. Okay. My title of the paper is High Dissect, a new surgical technique in the management of complex posterior polar cataract. Friends, and we do not have any financial interest in the subject matter of this presentation. We know that the posterior polar cataract is a surgical challenge due to its associated high incidence of intraoperative posterior capsular disruption. With any routine phacoforceps or attempt to detach the cataractous plaque may lead to complete pre-extraction disruption of the posterior capsule. Various incidences have been put forward, up to 36 to 40% PCR by most of the leading surgeons. And various techniques have been described to deal with the posterior polar cataract. Slow motion phaco, step-by-step chop in situ and lateral separation, lambda sculpting and cracking by various authors. And the important point is most of these techniques, they are suitable for the simple posterior polar cataract where you have a posterior capsule intact and it's thin but it's vulnerable to any kind of forces may disrupt. So these techniques are very suitable for all these cases, but what about the treacherous complex posterior polar cataract with posterior capsular anomaly? Because these are the cases where you have a posterior capsular defect, already existing posterior capsular defect, you may have a rent. There could be a complete adhesion of the posterior capsule with the plaque. So if you have a complete adhesion of the plaque, then taking out that plaque from the posterior capsule becomes very difficult. So the purpose of this study or the technique is to describe efficacy of a new surgical approach, high dissect, in the management of complex posterior polar cataract, and especially in minimizing the risk of further disruption of the posterior capsule and prevent posterior segment complications, and also in preventing pre-extraction posterior capsular disruption. We took up 22 cases of posterior polar cataract from our OPD during the year 2016 and 17. And on the basis of clinical examination, cases were grouped into two simple and complex posterior polar cataract. Cases of complex posterior polar cataract were included in this study. Complete preoperative examination, including the biomicroscopy, anterior segment OCT, specular microscopic examination, fundus examination, and as and when required, fundus fluorescence angiography and the posterior segment OCT was done. All the 10 cases of complex posterior polar cataract underwent high dissect technique. High dissect, what is high dissect? It is the bimanual irrigation aspiration cannula controlled dissection, separation, and extraction of the cortical matter, epinuclear membrane, and polar cataractous plaque, simultaneous posterior capsular axis. So here we are not using the phaco probe to directly aspirate as we do normally. With the phaco only, we try to extract the complete complex of the cataractous complex, where you extract that plaque also, and may lead to the complete disruption of the posterior capsule and then the complications. So looking at this video, you can see like we take all the care, all the standard technique to start with the posterior polar cataract, limited anterior chamber inflation, multi-quadrant hydrodissection. We have to avoid the cortical cleaving hydrodissection, and hydrodelineation, and the removal of the nucleus with a simple divide and conquer technique, like you just hold the nucleus without putting any pressure on the posterior capsule, take out the nucleus. So these are the standard practice we do in most of the time when we are dealing with the posterior polar cataract. Now the technique comes here. So we are using now the irrigation and aspiration cannula. Now for the rest of the aspiration of the cortex, epinucleus. And you can see here, what I'm trying to do is I'm removing the cortex and preserving that plaque on the posterior capsule, so that you are basically putting a pressure on the posterior capsule, so that you do not get into the problem of the complete disruption in the beginning itself. So this is the plaque, and then finally I'm using the aspiration cannula, because you cannot hold this plaque with the forces, it's friable matter. So you have to use the vacuum to extract, and extraction has to be very slow, as you can see, because while extracting this plaque, I'm trying to put some sort of traction on the posterior capsule also, and trying to separate it and creating a posterior capsular rhexis also. So you can see this is a slow motion, because I have done a lot of this to shorten the video. So you won't be able to see the complete technique, but yes, some part of the technique. And then once you have removed it, and you can see the posterior capsular defect is well maintained without the loss of the vitreous, but this has to be done very slowly with the aspiration cannula only. And these are the cases where so the important point which I want to show here is we did a successful PCC in 9 cases out of the 10 cases. Vitrectomy was required only in one case. In the bag, IOL was placed in 9 cases, and sulcus IOL was placed in 1 case. The visual improvement was excellent in all the cases where. So to conclude, high dissect, bimanual, low vacuum controlled aspiration of the cataractous plaque while creating a controlled posterior capsular axis is the most suitable surgical approach in the management of complex posterior polar cataract to prevent pre-extraction disruption of the posterior capsule and to prevent possible potential complications in which we come across with the PCR. Thank you.
Thank you, sir. Only one question I would like to ask. Was there any sign of Daljit sign or a fishtail sign seen in these patients on a slit lamp demonstrating?
I didn't hear. What were you asking?
Did they have a fishtail sign, these patients, indicating preoperatively that there may be a defect onto the posterior capsule, or they just onion peel type of posterior polar cataracts?
See, actually, I've already shown in the first picture. In the first picture, it's very clearly showed. You can see on clinical examination itself with the slit lamp, you can see the defect. If not, then you can confirm it with the OCT. So OCT is the very important, rather than looking at the signs and the onion peel and this. You may not get the complete picture, but if you do the OCT, you will definitely 100% know that there is a PC defect. So in all the cases, OCT was done, and it was confirmed with the OCT only. But in the clinical examination with the slit lamp also, in almost 60-70% of the cases, you can very clearly see the defect.
Right, sir.
Sir, thank you, sir. That's a beautiful technique. And you have magical hands to have done a posterior capsular rhexis without using the viscoelastic to stabilize the chamber, sir.
Yeah, that's
why.
There
is a nice paper from Hong Kong, sir, dividing posterior polar cataracts into 3 groups based on AS OCT findings. Basically, they came to the conclusion around 5% of them have a pre-existing rent and they have a posterior bulge. Right. So did your AS-OCT show any of your patients with a pre-existing posterior capsular disruption and a bulge into the vitreous?
No. So actually, that is what I showed. Only in one case, we lost the vitreous, and there we had to do the vitrectomy and place. That's why I'm saying, because in most of these cases where you have a PC defect and already existing PC defect, the vitreous space is very tight. So this is my experience, yes, because most of them have the tight because it's exposed vitreous. So yes, you have it like what you see post-operatively. If you happen to get the post-PC rupture and the vitreous face is intact, you just see these patients after a month or so, the vitreous face would become much stiffer and hardened.
Yes.
So similar picture you find intraoperatively in these cases where you have a PC defect. The vitreous will not lose unless you try to remove that plaque forcefully under where it is adhered. Then you may have a vitreous prolapse.
Thank you, sir.
Thanks, sir. It was really beautiful.
Actually, it is the skill which matters more.
Yeah, he's a surgeon with so many of innovations under his belt. So it was really pleasure, sir.
Done. Thank you. It's yours.
So we thank all the speakers for wonderful presentations and the panelists, Dr. Renuka Srinivasan, Dr. Pattanayak Sabyasachi, Dr. Jeevan Ladi, Dr. Professor Anand Bandari.
I now remember.
And it was, and all the audience also, and the organizers.
Thank you. Thank you, sir. Yes, sir, sure. Please come forward.